Hello, everyone. My name is Alanna Monson-Zeiger, and I am here to present my presentation on my hypothetical client, Jenny. So without further ado, let me share my screen and get started with my presentation. Okay, play from the start. Okay, so this is my final case conceptualization. I have been working with Jenny's case over the last 7 or so weeks, and this is my final case conceptualization. So, a little background on Jenny. She is a 43-year-old married Caucasian female. She has one adult son who is 19 years old, who was living in the home. Um, she was employed full time. She managed housing for the Department of Defense employees when they came into the area. She was very satisfied with her job, and it gave her a lot of purpose and meaning. Another thing that adds a lot of meaning and purpose to her life is attending church. She has a strong spiritual orientation, and she works in the nursery with children, and she calls them my kids. That adds a lot of meaning and joy to her life. 3 years ago, she started experiencing chronic pain, carpal tunnel pain in her wrist. And she did occupational therapy, physical therapy, and other interventions to try and relieve the pain. Nothing was successful, so she has been on prescription painkillers for the last 3 years. Something to note is that it's a pretty lax pain clinic, so as long as she can present to the clinic every 30 days with a clean urine screening, she can get her painkillers every 30 days. Something else to note is that she has had unsuccessful attempts at tapering or completely stopping her painkillers because of the pain in her wrist. Um, she presented to substance use counseling amidst the COVID-19 pandemic, which many of us around the planet lost our jobs or transitioned solely to remote work. So Jenny was in the class of people who lost their job. Their husband or her husband transitioned to working from home, and her son, as an essential worker, had to move out of the home to minimize risk of infecting his parents. So those are some recent family changes. Alcohol use. So her main substance use issue that she was referred to counseling for is her increased use of alcohol. So at the start of the pandemic, she started having 1 glass of wine with dinner. She did this because it felt like she was going out, and it sort of brought the fun experience of going out into the home during quarantine periods. And over that span of time, 1 glass of wine has increased to 8 mini bottles of wine per day. She was referred to substance use counseling by her pain doctor because her husband butted in on a telehealth session and said, I bet you haven't told him you've been drinking every day, have you? And that prompted her pain management provider to refer her to substance use counseling because she is now at risk of losing her painkiller prescription because her pain management provider now knows that she is combining alcohol and her prescription painkillers. And her husband has expressed concern about this, and this has created some tension in the home as well. So that's Jenny. So that is some background information on Jenny. So the first step in really all counseling, especially substance use disorder counseling, is assessment. And although this is the first step in all counseling, it is an ongoing process all the way until termination. So the assessment device that I chose to implement with Jenny is the audit, the alcohol use disorder identification test. This was developed by the World Health Organization, and one of the strengths of this assessment is that it assesses alcohol use along a continuum of severity. So beginning at sort of less than problematic, more at risk alcohol behaviors, all the way to a very severe alcohol use pattern. It also shows sufficient validity and reliability across a wide range of cultures and sexual and gender diversity. I would assume that it would be safe to use with Jenny. Um, Something to note, especially when using this device with women or other marginalized group, is that reducing cutoff scores can result in connecting more people of marginalized cultures to treatment, especially because those groups experience other additional barriers to treatment. So Jenny's diagnoses and levels of severity. So based on everything I told you about Jenny, these are the diagnoses that I was able to confirm using the Diagnostic and Statistical Manual of Mental Disorders. So her primary diagnosis would be alcohol use disorder, severe. The symptoms that would indicate this diagnosis include alcohol taken in larger amounts over a span of time, and that is exhibited by increasing her alcohol consumption from 1 glass of wine to 8 mini bottles of wine. Um, Social and interpersonal problems. She is experiencing some tension with her husband about this, so we could count that as a symptom. She has a lot of hobbies, aside from her job that brings her purpose and going to church that brings her purpose. She also is very creative. She likes to knit. She likes to do intellectual activities like puzzles and crossword. Um, and she gave those up during the pandemic due to increased boredom. They just didn't seem to satisfy her in a way that they used to, especially since beginning drinking. Um, Drinking in hazardous situations, she combines her prescription painkillers, which are opiates, with alcohol, and that is definitely hazardous. Um, and she is continuing to drink despite exacerbated physical and psychological problems. She came to counseling with pretty low motivation to quit drinking, despite her pain management provider expressing some pretty significant concern about her physical health and what this could mean for her. And and her increased use of alcohol is likely an indicator of increased tolerance. So, with those 6 symptoms, I was able to come up with a severe diagnosis. According to the DSM, 6 or more symptoms would indicate a severe diagnosis. Um, Other diagnoses to consider include opioid use disorder, major depressive disorder, and substance/medication induced depressive disorder. And I added the latter 2 diagnoses because she does endorse the symptom of anhedonia, and I'll talk more about that in the next slide. Um, Diagnoses I was able to rule out are opioid use disorder, because her opioid use is restricted to medications prescribed and monitored by her physician. That doesn't really necessarily count for a diagnosis of opioid use. Opioid use, however, if she were to indicate that she has sourced opioids in another way, like outside of her pain management provider, then maybe we would be able to diagnose something there. But because her opioid use is restricted to what is monitored by her doctor, we can rule that out. So more information that I would need to strengthen her existing diagnosis of alcohol use disorder and possibly diagnosing her with a depressive disorder. The only confirmed symptom, like I said, is anhedonia, exhibited by her lack of interest in her hobbies that once brought her joy. And also like some contextual um, information that is helpful is that she doesn't have access to a lot of the social activities that brought her joy due to the COVID-19 pandemic. Um, More information is definitely needed on the quality of her mood, changes in energy levels or sleep quality, changes in appetite or weight, feelings of worthlessness or guilt, thoughts of death and suicide, and what her concentration's like. And also the severity of distress and impairment that these mood related symptoms cause her, because it seems she did say that her drinking and otherwise other symptoms don't necessarily impact her from doing all the things she needs to do around the home, and they didn't, and her prescription opioid use didn't impact her ability to function well at work either. So, um, her level of distress and impairment seemed low based on the baseline information I was given. So, differentiating between major depressive disorder and substance/medication induced depressive disorder, this has to do with timing of symptoms. In substance/medication induced depressive disorder, um, symptoms would have to occur soon or shortly thereafter, intoxication or withdrawal from a substance or medication. And and it would be helpful to know if she was experiencing any anhedonia or issues with her mood before her alcohol use increased. So it'd be helpful to know the timeline to differentiate between those two diagnoses. In alcohol use, some more information may be needed on her alcohol use. Um, Not much was said about her cravings for alcohol. It could be assumed that she has a craving for alcohol. Previous attempts to reduce alcohol or quit, nothing was said about that. Time spent acquiring, using, and or recovering from alcohol, not much has been said about that. And not much has been said about symptoms of withdrawal. So those are all things to continue to assess for that could change her diagnoses or impact them. So based on this information, um, this is the recommended level of care I would refer Jenny to. Um, I use the American Society of Addiction Medicine dimensions of assessment in their levels of care. It is probably the most popular in addictions counseling and substance use treatment. So the six dimensions of assessment that ASAM uh, encourages substance use providers to assess for include acute intoxication and withdrawal potential, biomedical conditions and complications, emotional, cognitive, and behavioral conditions, readiness to change, relapse, continued use, and continued problem potential and recovery environment. And the corresponding levels of care include outpatient treatment, intensive outpatient treatment or partial hospitalization, residential or inpatient treatment, and intensive inpatient treatment/medical detox. Another tool or set of guidelines that substance use providers can also look to outside of ASAM is the level of care for alcohol and drug treatment referral. It's an assessment tool that has sufficient reliability and validity, and in the assessment dimensions are similar to ASAM's. They're just a little bit more concise. And this is also a good option that could be helpful. So continued, using those guidelines, I would recommend that Jenny first be referred to medical detoxification and then transferred to a low intensity residential treatment. Um, However, um, given some certain considerations, it may be more beneficial to refer her to partial hospitalization over residential and I will get to that in a minute. So my rationale for recommending this level of care, mainly using ASAM's guidelines and some of the locators guidelines. Excuse me. She shows. Sorry, let me find the right words. So her using alcohol in combination with her prescription opioids raises concerns about her acute withdrawal potential and her pain possibly being exacerbated if she has to withdraw from both of those substances at the same time. Um, and because she struggles with chronic pain, it would just be best for her tapering off of alcohol to be in a medically managed environment, especially because she has pre-existing health conditions and pain. Um, she also shows a lack of readiness to change. So simply referring her to an outpatient or intensive outpatient treatment raises concerns since she kind of doesn't seem to think that her drinking is an issue and doesn't want to stop. Um, it kind of raises concerns whether she would follow through on going with appointments, and being honest in those appointments. And she has a reduced social support network and some increased tension at home with her husband and recent family changes. So it may be beneficial to have her in a therapeutic milieu of people, even better, a milieu of women where she can strengthen a social support of people going through a similar experience. And this could be also accomplished in a partial hospitalization program as well. There just would need to be some adjustments to the recovery environment. So, how I ruled out other levels of care, like I said, outpatient and intensive outpatient, because of her readiness to change, she is likely to continue drinking. There's too many medical complications, um, and her recovery environment may not be all that supportive. More information is needed on whether her husband drinks and if he keeps alcohol in the home. Um, he may need some coaching on how to communicate with Jenny in a way that doesn't shame her. So her recovery environment may need some adjustments. Ruling out PHP, she may continue to need 24-hour monitoring and medical care because of her chronic pain condition, and they may be able to connect her with other forms of pain management. And she would just have more time in the therapeutic community in residential. Like I said, she would need to make some changes to her recovery environment. She would need to make a stronger commitment to abstinence, and she would need to show proof of psychological stability, which she shows. She seems to show signs of psychological stability. So it may be the more parsimonious choice to place her in PHP because she would still get the benefit of a therapeutic milieu in receiving medical care. She just would be able to have nights and weekends at home in her comfort space. So ethical and cultural considerations that are of importance here. So, primary ethical concerns using the American Counseling Association Code of Ethics, because I'm in a counseling program, that's my code of ethics that I must abide to. So, informed consent and confidentiality during telehealth sessions is going to be huge for Jenny, especially if she continues to see me an outpatient or if she continues in like a virtual partial hospitalization program, because those do exist. It would be really paramount to have that conversation with Jenny that she is in a private space and minimize the risk of her husband coming in and interfering with appointments and things like that. Because that happened during her pain management appointment. There was kind of a privacy violation there with her husband butting in and and informing her about certain risks to confidentiality in the virtual environment would be really important, especially because they're amidst the COVID-19 pandemic. And in this is also getting full informed consent from Jenny, letting her know what to expect in treatment, um, what to expect in virtual treatment, um, kind of her rights and responsibilities, my rights and responsibilities, and the such. Next would be confidentiality and coordination of care because Jenny has a pain management provider and she would likely be referred from medical detox to residential to lower or even to a lower level of care. For continuity of care, it's probably going to be really important that all of these providers communicate with one another and having Jenny make sure that she understands the purpose of sharing information with other providers and that it's for her benefit and for um, better coordination of care for her and to make sure that she goes through the release of information process and understands everything that that entails. Also, in treating any kind of substance use, especially doing it online, working within one's boundaries of competence in acquiring continued education and making appropriate referrals when a client comes to you with an issue that is outside of your boundary of competence, or when clients may need a higher level of care than you can provide. Um, those are the primary ethical concerns that I would see arising with Jenny. Cultural considerations. Um, Women are traditionally understudied in many areas of healthcare research, and especially in addictions research. So there's a lot of gender-specific considerations in treating alcohol use disorder in women, notably caregiver responsibilities, homemaker responsibilities. There's a lot of treatment gaps and barriers to treatment that women experience that men maybe don't. Women often present to substance use treatment with more psychological comorbidities and trauma. So there's a higher need for trauma-informed care. Um, and I've mentioned many times throughout this presentation already that they are in the global pandemic. And we all remember what that was like because it was only 5 years ago. There was a lot of sociocultural changes that happened in the United States and around the world at large. And research has shown that alcohol consumption in women increased during the COVID-19 pandemic, and those patterns have continued. And a study by Tucker and colleagues found that one of the factors that increases the likelihood of increased alcohol consumption is social isolation and loneliness in women, and that showed to be more of a factor in women than men. So healing through connection seems to be a big protective factor for women in recovery. So the first theory, sorry, the first theoretical background or theory or model that I would like to use with Jenny that I think would be helpful is motivational interviewing. This was designed by Miller and Rolnick for individuals who present to substance use treatment or are referred to substance use treatment who lack motivation or simply just don't want to stop drinking or abstain from any kind of substance use. And the purpose of motivational interviewing is to move clients through the stages of change. Which is Prochaska's model. Um, so this is a pretty brief model. It ranges from 1 to maybe 4 or 5 sessions. And there are 4 guiding principles of motivational interviewing. It is less of an intervention, less of a technique, and more of a way of being, more of a way of presenting yourself to clients, more of a way of approaching clients. So these are the 4 principles. Expressing empathy, developing a discrepancy between behavior and values, rolling with clients' resistance, and supporting client self-efficacy. So these 4 principles would point one to think that this is very person-centered, and one would be right. This is a very person-centered paradigm. However, it is also very directive. It elicits behavior change through directive change talk and supporting clients exactly where they are. And research shows that meeting clients where they are, whether that be in resistance and meeting clients where they are in that resistance instead of trying to fight it or engage in power struggles, has been shown to reduce clients' resistance. So it's very person-centered, client-centered technique. So certain techniques that kind of fall in this umbrella include empathetic listening, which would show up in all counseling, I would argue. Respecting clients' autonomy. Change talk is huge in motivational interviewing. And this is when counselors pick apart what clients say and point out statements that show evidence of a desire to change. And also giving structured feedback. That's what's really great about motivational interviewing. The directive piece is that structured feedback component. And the use of confidence rulers is another motivational interviewing technique to assess how confident clients feel in abstaining from drinking or even reducing their substance use, and creating action plans and change plans with like goals and objectives. So, more about motivational interviewing. Some research has shown that intensive motivational interviewing is helpful for women with alcohol use disorder. So it's the same strategies, same kind of ways of being as motivational interviewing. It's just the duration of the treatment is increased to 9 sessions. And the extra sessions allow more time for developing that change plan and going back and maybe modifying some things and really fine-tuning the change plan. And there is gender-specific considerations and modifications that have been added to this that have shown to be effective for women. So including the roles of relationships and parenting, acknowledging history of trauma or abuse, tending to self-esteem in addition to self-efficacy, addressing barriers to treatment and giving women a space to talk about that, and addressing co-occurring physical and mental health conditions. Um, and this was found to be more effective at reducing drinking at the 12-month follow-up with women with more severe alcohol use. So that pointed me in the direction with Jenny since she is in the severe, uh, she's on the severe end of the dimension of alcohol use. However, there are better outcomes with intensive motivational interviewing with women that come into treatment with higher motivation. And since Jenny's coming into treatment with particularly low motivation, she may need a little extra work on rolling with her resistance. So the second model that would be helpful for Jenny once she has entered treatment and her motivations to quit drinking and continue recovery have increased, cognitive behavior therapy is another leading um, paradigm or model for treating substance use and a variety of other mental health issues. As we all probably know, Aaron Beck developed CBT in the 1960s, and the idea behind CBT is that we are eliciting behavior change through changing our thoughts and changing the way we think about the world and about ourselves and the like. Something to keep in mind about models or theories created by white men in of a particular time is that they were developed in a white male middle class frame of reference. So it's important to keep that in mind. However, CBT has been tested many of times with a variety of cultures and gender and sexual and gender diversity. So it is a culturally responsive treatment when it is adapted. Um, so the CBT counselor would perceive problematic drinking as a result of poor coping skills and reduced self-efficacy. So this links also to kind of the strategies in motivational interviewing as well. So the primary treatment goals in CBT for substance use is to increase abstinence self-efficacy and introduce coping skills to use in place of target behavior. So strategies used in CBT for alcohol use disorder include coping skills training, that could include mindfulness-based training, um, emotion regulation training, distress tolerance training, um, interpersonal skills training, intrapersonal skills training, another hallmark CBT intervention is assigning homework for clients to complete in between sessions. So a lot of that may include journaling, tracking moods and emotions, um, cognitive modification or reframing unhelpful thoughts or ineffective thoughts surrounding alcohol or substance use, providing psychoeducation about the importance of coping skills and how alcohol impacts our mental health or other substances impact our mental health, behavior analysis of following through on drinking or said target behavior, and going and following through with like relapse prevention, like active relapse prevention. So some more about CBT. It is It has proven to be effective at promoting abstinence in a variety of clinical samples, variety of cultures, sexual gender diversity. Like I said, it is shown to significantly increase self-efficacy and coping skills quickly upon initiating abstinence. One study found that within 1 week of initiating abstinence, abstinence self-efficacy significantly increases under like the CBT framework. So that's promising. Um, it has been adapted to be more suitable for women. So female specific CBT for women with alcohol use disorder, it's equally as effective as gender neutral CBT in women with alcohol use disorder, and it was mainly modified to emphasize an increased sense of autonomy and strengthening social networks. So, because Jenny feels socially isolated, and it seems that a lot of her healing may come through connection, that female specific CBT may be a suitable option for her. So, Jenny's treatment plan. So, the first goal that we would like to address is stabilizing her alcohol use and commit to abstinence without compromising her physical health or increasing her pain levels. So, the interventions to use to achieve this goal is to instruct Jenny to identify two core values and two goals that are impacted by alcohol use. So, this could include like her values of family and connection to others and how that could be impacted by alcohol use. That intervention is mainly seeing how substance use often falls outside of our value system and our goals. Intervention two, so collaboratively develop a recovery and relapse prevention plan and implement once transferred from medical detox. Um, this is what I would be able to do with Jenny while she's in medical detox. It would be helpful to be able to see her virtually and be able to increase her motivation to enter a lower level of care once she's done with medical detoxification, um, in creating that change plan and including a relapse prevention plan in that change plan may be helpful with Jenny in this first stage of treatment. Um, and engaging in change talk. So highlighting Jenny's statements that indicate a desire to abstain from alcohol. So Jenny may indicate that she wants her relationship with her husband to improve. She may state that she is scared about losing her prescription opioids for her chronic pain. So those could be statements that may point to a desire to abstain from alcohol. So her second goal would be to develop coping skills and strengthen her social support network. So the first intervention I would use is to engage Jenny in mindfulness-based skills training and instruct Jenny to engage in 5 minutes of mindfulness per day. She can track this via a journal or a chart that I create for her. Intervention two would be to refer Jenny to an online women's recovery support group that meets weekly, that she can continue with when she is transferred out of a higher level of care. And then intervention three would be to instruct Jenny to plan at least 2 activities a week that bring her joy or contribute to her self-care. Um, and this may involve like attending church online or things like that. Um, and these goals would be helpful to do while she's in residential treatment and once she is transferred out of a higher level of care, um, it may be helpful to continue working on these goals when she is transferred from residential or PHP to outpatient. Also, it is helpful to note that like medical detox takes about a week. So that's a really short amount of time. And residential treatment is also not necessarily long term as well. Those would be more of a 30-day, so a 30-day stay. So much of Jenny's recovery journey would be in a intensive outpatient or outpatient care, considering that partial hospitalization programs and residential treatment programs are shorter. Um, So that is kind of duration of treatment details. So Jenny's relapse prevention plan, because a lot of her interventions and goals are very CBT oriented, I chose to look to Marlett and Golden's cognitive behavioral relapse prevention plan. Um, why this was so attractive to me is that this model views relapse as a continuous process as opposed to isolated events. Um, and they also use a biopsychosocial conceptualization of recovery and relapse, like taking into account emotions, behaviors, environmental considerations, body sensations. They kind of take a comprehensive, holistic view of recovery and relapse. And they approach relapse prevention in a two-pronged approach by oh gosh, the balloons, by identifying high-risk situations and triggers and developing necessary coping skills at the same time. So relapse prevention for Jenny, her role would be to identify events, people, situations, and emotions that trigger her to drink. And the increased amount of time at home may be the biggest trigger, indicating that residential or PHP may be or residential may be a better level of care for her. Her role is also to engage her pre-existing support system. It sounds like she has a good relationship with her son, and her husband is really concerned about her well-being. So it'd be helpful for her to engage her pre-existing support system and asking them for support in ways that she may need a little extra help. Such as like structuring her recovery environment or the way they speak to her about her drinking and things like that. Um, Jenny's role is also to develop a list of alternative activities and coping skills to implement during times of craving or times of distress, or especially times of boredom, because it seems like boredom is a big precipitating factor to her drinking. So my role would be to provide psychoeducation and skills training on mindfulness and distress tolerance and coaching Jenny's support system to be more recovery oriented. I would also argue that interpersonal effectiveness and emotion regulation skills would be helpful as well. So that was my presentation on Jenny, and these are my references. As you can tell, I am very CBT/DBT oriented, and thoroughly enjoyed uh, working with this case and learning more about it. So I hope you guys enjoyed it and learned a lot as well. And I'm excited to view your presentations.